PII, personally identifying information, especially as this is being recorded. If that is happening, I will pause the action and ask, I will just make people mindful this is going on. Please don't do that. We don't want people to be sharing more information than they really want to be. I understand we are using the speaker's queue as well as the chat box. So there are people in this meeting, staff, who are managing questions through the chat box. There will be points where we will ask for verbal comments, in which case you would use the hand icon down at the bottom of your screen. Or if you are on the phone only, looks like we have one person who may or may not only be on the phone, but you raise your hand, I will take those names and I will work through them and call on people. If you raise your hand to make a comment or ask a question, you get one comment, one question, and a 2-minute time limit, because we want to hear from as many people as we can. So if you have a follow-up question, you can raise your hand again and go to the back of the queue and we'll work through. And that's how we'll do it. I will give people a 15-second reminder or heads up that their 2 minutes are coming to an end. I will do that as politely as I can. I know it's an intrusion, but you can get the slides. There's a link for that on the screen. If you're listening by phone, again, press star to unmute or mute yourself. And there's a link there for online resources. So thanks, everybody. Next slide, please. Okay, this is the meeting. I'm going to turn this over to Candace at this point. If I missed anything, which I usually do, Candace fills it in. So.
Thank you so much, John. Very rarely do you miss anything. I will tell you that. We're very grateful for your support here. Good morning, everybody. My name is Candace Bailey, and I am the HCBS Division Director in the Office of Community Living. And we are here for meeting number 4, talking about private duty nursing rules. So that's very exciting. It is the last day of August. Also very exciting for some people who enjoy fall. Tomorrow is the first day of September, which is really shocking to me. So we'll go through the purpose of these meetings. Really, the purpose is to engage stakeholders. We really want to get feedback from everybody, providers, advocates, members, case managers, anybody that is interested and has vested interest in these rules, with how we are revising things and what we need to change. Next slide, please. Here's our introductions, our agenda. Forgive me. So we'll go through real quick HCPF introductions. I'll run through kind of who's here. We have an attendance form that we're asking. Cassie put the link in the chat. We're asking folks to fill that out just so we kind of are able to understand who's here and who is able to provide feedback. We'll go through some guidelines, just general meeting guidelines that are pretty basic. And then we'll get into the meat of our presentation, which is going through our rules. Then we'll have our discussion and our next steps. So first and foremost, HCPF introductions. Obviously, my name is Candace Bailey, and I have a slew of folks that are here with me that are integral to all of the things. My apologies, there's somebody knocking on my door. I am in a hotel room because I was presenting at a conference yesterday. So sorry. Okay, Christine, can you handle the introductions for me really quick for HCPF?
Yep. Good morning, everyone. My name is Christine Merriman. I am the Home Health and Private Duty Nursing Policy Advisor. I'm also the face behind the Home Health inbox for when you have questions or need assistance. You'll usually get me. With us, we have Erin Thatcher and Cassie Keller. We also have Paul Hutchings, who is my counterpart for all things home health. And then we have some folks from CCQI as well that are joining us on the clinical side of things.
Thank you, Christine. My apologies. Always a fun time when you shake things up a little bit. I was like, I can present from a conference. It's fine. All right, next slide, please. Okay, so just a couple of housekeeping things. None of this is new. Please make sure you are muting your computer or the phone when you are not speaking. If you are not muted, oftentimes the background noise makes it really hard for other folks to hear. Please raise your hand and unmute yourself when you have a comment or a question, or unmute yourself when you've been called upon. John is going to do the speaker's queue, which works really well. We have a chat box that you can enter comments, questions, suggestions, things like that. We track every single comment and suggestion that comes in, and it is actually then posted online with a response. So please use the chat box. It is super, super helpful. Please, please, please do not disclose any protected health information. We are recording this meeting. If we have any PHI, we actually cannot post this meeting. So please, please, please do not disclose any sort of protected health information, because there are a lot of individuals that have an interest in this meeting that are not able to attend, and I really want to honor their ability to listen to this later. The team will answer questions as we can going through, but keep in mind that not every single question is likely going to be answered, but we will get to it later. Next slide, please. All right, so here's our process. Basically we're starting with the various meetings to go through the different sections of the rule. That is most of this year, quite frankly. We started in February. We are now at the end of August, and we have at least one, if not two more meetings that we're going to need to have. And then after we go through that, we get all of the stakeholder feedback. We come to a final draft, if you will. We are not there yet. Let me be clear. When we get to that point, then we'll go through our clearance process, make sure, we have our legal team reviews, the Attorney General's review, all of that good stuff. Then we'll present it to the Medical Services Board. And then hopefully in spring, we will have new revised rules effective. Next slide, please. So here are our goals for these revisions. We really want to go through and update anything that's outdated, clarify some orders, just rework things so that the rules in the services are much more clear, they're understandable, and up to date. So those are our goals. Next slide, please. Overview. So here is the overview. So what we did is, presenting an entire rule all at once, especially something as large as private duty nursing, is way too much for one meeting. It just is. And so what we did was we actually broke it down by section to hopefully try to make it easier and allow us to really focus in our discussions and our conversations a little bit. Was it ideal or was it perfect state? Of course not, but there is no perfect state, right? So we did the best that we could as far as picking out the different sections and what worked and what order we needed to go in. Today, we're going to discuss benefits, benefit limitations, eligibility, and application procedures. So I will note, I did see Katie's comment in the chat. I also got your email, Katie. Thank you very much for your feedback. We are not done. So we are going to have another meeting that will go over both definitions and the entirety of the rule. So these rules will not go to the Medical Services Board prior to everybody having a chance to provide feedback on the entirety of it. So what we're doing is, like I said, we went section by section. We're going to take those sections, put it all together in one big giant rule packet. We will then, for the next meeting, go through the entirety of it so we can talk through the changes that we made and really dig into some areas where we still need to have some discussions because not everything is resolved, obviously. And so that is on the docket for our next meeting where we will go through the entirety of the rule, including definitions. Will that full rule packet be a second draft? I don't really understand the difference. It's still just a draft. It'll just be basically a combined draft. Instead of having it broken apart by sections, it'll be one combined draft is what it will be. Next slide, please. So this just kind of goes through what we've done to date. The different areas that we went through in February, April, June, and then today. I'm going to pause really quick because I see Katie has a lot of questions and see if I can clarify. Will that full rule packet be a full draft?
Sorry, I'm just trying to understand the process that you're saying. Will the whole packet just be this same draft that we've discussed already, or will it incorporate the changes from our meetings? That's what I'm
It will incorporate changes from the meetings.
Thank you. Got it. Thanks.
You're welcome. Okay. All right. Next slide, please. Okay, so general consideration. So some things we really want you all to keep in mind and to remember as we're going through this. None of this is final, right? We are not there yet. So language and concepts and things that are discussed are not final. We are taking back and documenting all of your feedback, all of your ideas. Again, we take every single comment and question that comes in through the chat, through email, and we post it online. We have a listening log that is updated at the very least after every single meeting. But in addition, if we get a whole slew of additional questions that come in, we update it then as well. There's going to be certain words that are going to be changed throughout. So we are changing the word client to member throughout the entirety of our rules. Some areas, all we're doing is reorganizing things because sometimes the organization helps clarify how things work. And so we are trying to make it a lot easier and simpler to read and go through. Let's see here. We really, really, really want your feedback. I really, really, really want your participation. The goal of these meetings is to get your feedback to make the changes that are necessary. And so we are here because we need your help. Next slide, please. Okay, so here are some things that I wanted to point out that we are still in discussion. So there is a lot of things that are not final. So Katie, to your point, these items are likely not going to be in the next draft, the combined draft that we put out for our next meeting, because we still need to have more conversations, more in-depth conversations around a lot of these. So some of them include, a process to transfer PARs between agencies, clarifying expiration dates. We still have to go through definitions, termination of services and procedures, denial timeline. So there's a number of things. Group ratios, that's a really big one that we really need to have a much more in-depth conversation with this group around group ratios and what those should look like going forward. So these are some areas where we know we need to dig in deeper with you all. So get ready, because we're going to ask for a lot of feedback and input next time we meet as well. Next slide, please. Okay, so for today, we're going to talk about benefits and eligibility. So we're going to go ahead and get started before we jump into the topics for today. So the sections we are focusing in on today. John, I'd like to open it up and see if folks have questions about previous topics or any of the information I've provided thus far.
Very good, Candace. So folks, if you do, would you please raise your hand in the webinar using the little hand icon and let us know that you do have a question about previous topics. I am seeing none so far.
All right, well, I guess that means we can move on.
Okay.
Thanks, John. Will you go back one slide? Sorry. Thank you. Okay, so here's what we're going to be talking about. The suggested revisions are removing outdated language, reorganization, in the 4 distinct sections. Okay, now I'm ready. Thank you. So just to give you the key for how this works, anything that is underlined is added language. Anything that is highlighted has been renumbered or reorganized, so kind of moved around within the document. And anything that's in red lettering and has a strike through, we are proposing to remove. So that's our key for today. Next slide, please. Okay. So this section, as you can see, we are proposing striking it, essentially. It's very old, outdated language. It's about when we were restarting the PARs back in November 2021. It is no longer necessary. So we are going to remove that section. Pretty simple. Next slide. There we go. Here is some really good new information that we're looking to do, or add, sorry. This is all, hopefully you all have had a chance to read it. I'm not going to read it all to you all, but it really goes through some benefits. It helps clarify and added all this language to clarify the benefit and what is covered within private duty nursing. So all new language. Next slide, please. This is how the benefits section is currently written. Next slide, please. And this is the proposed changes. So we are proposing adding, clarifying that a pediatric member is age 20 and younger, and kind of what that process looks like. we're going to strike a lot of this language. It is confusing and unnecessary. Pediatric members are not required to be technologically dependent, anything like that. So to make sure that is super clear, we are striking that language. And so this actually is breaking apart kind of the definition for a pediatric member and an adult member later. Next slide, please. Benefits. So this is the benefit section that's currently how it is written. So this is what it looks like right now. It's not super clear, obviously, as you can see, between pediatrics and adults. Next slide, please. And so here we are clarifying the specifics around what is an adult and some benefits, and to be clear around their eligibility here and what the benefit is. I see Katie has a question, and I think now is a great time to pause and take some questions.
Okay, thank you, Candace. So we have one in the queue so far, which is Katie. Anyone else? And you please raise your hand if you want to get into the speaker's queue. I ask for other hands, even though we have one so far, so we can budget our time accordingly. Okay, Katie, please go ahead. You have 2 minutes. Thank you.
Thank you. I appreciate it. For the current slide, I did put a comment, which I know will be logged, so we don't need to discuss that. I just had questions about what good cause meant, because it's not defined, and it seems like there's trying to be a separation between a change in circumstances. So I had questions about that. But in this slide that's up here now, I think the language that says here, medical necessity criteria identified by HCPF and used by the URC. Medical necessity criteria is not identified by HCPF. It has to be in rule, or it's going to be an unascertainable standard, right? We can't just say HCPF is going to decide what medical necessity criteria is. It should just be referenced in the rule of what that definition is. And so go ahead.
I was going to say, Michelle, I believe we have medical necessity identified or defined in a different area. Christine's nodding her head yes.
Yeah, but I think that's what you're saying too, I think brings up the point of we would absolutely also refer, I believe, in this rule back to the 2 medical necessity definitions that are in rule. So I think you're right. We've got some area that is specific to this benefit further on, and we need to remember that medical necessity for like the regular one, and then there's an EPSDT one are also in rule. Right. So we'll definitely reference those as well.
Okay, thank you. I appreciate that. And I also just wanted to make a sort of a general comment about this draft. I went through and I think I counted like 6 or 7 places where it seems to be redefining or mentioning areas that I think should be in the PAR section that we did at the very beginning. And I think there's several parts that sort of introduce this level of ambiguity that I think is going to make the rule hard to implement, right? And it's going to require the URC or whoever's doing the PAR to reference not only the PAR section, but also here. So like we reference plans of care repeatedly, we reference a written treatment plan developed in coordination with the home health agency. There's just a bunch of different, and I'm happy to send this via email, but there's just several pieces here where it seems to repeat sections of the PAR that I don't think need to be repeated, and that I think introduce this level of ambiguity sort of throughout the rule. So again, I'm happy to follow up with an email with that.
Yeah, an email would be super helpful for those specific sections. And so if, and we can take a look at that. But what I will say is that our vendor absolutely will have to be able to look at every section of our rule. That's one of the requirements for any of our vendors. Like they have to be able to follow the entirety of a rule, not just one particular section. So having a vendor have to look at multiple sections is okay. But I hear you that it sounds like perhaps we have some duplication, and we can absolutely take a look at that.
Yeah, I also think like right on this section in 2D,
Katie, this is John Barry. You have 15 seconds. Thank you.
It says that the home health agency should apply for additional hours. So it sounds like we're asking the home health agency to know when to apply, but I also just wanted to mention the home health agency is not mentioned at all in the PAR section. And I think it was in the previous drafts and was taken out. And so I just think there's
Katie, that's
clear.
Thank you. 2 minutes. Thank you.
Thank you, John. And I appreciate that. And I think it is mentioned, but we'll go back and take a look. And so again, if you have the specific points that you're willing to send via email, that would be helpful. And all of that will go in our listening log. So everybody can see kind of the points that you brought up and the specific sections of the rule, and then our response. So thank you so much.
Candace and team, this is John. I thought we had someone else who had raised their hand earlier.
Thought so too. I thought it was Erica, but she looks like maybe she put it.
Changed her mind. Erica, if that
Yeah,
was
that's okay. I had the same question actually as Katie about the
Oh,
medical necessity and
okay.
if it was referenced or if it was something different that would be outside of the rule. And so I think that clarified it. And I think it would make it absolutely more clear if it was, cited within that rule where the medical necessity, is otherwise listed in rule, just so it doesn't feel like it's something else other than, just the contents of the rule and its like totality, I guess. And I just wanted to say thanks for clarifying the ages. That's very helpful.
Perfect. Thank you,
Okay.
Erica. I appreciate that.
Thank you, Erica. Claire Dixon, you are up next. Thank you. 2 minutes, please.
Yes, I just wanted to ask how, I know that the department has over many years said that it is going to redo the PDN acuity tool, and I believe that that work may still be in progress, but how does the acuity tool play into the medical necessity definition and all of the benefit limitations and eligibility criteria that are included in the rule? Since you do not have the new acuity tool yet, how do those things come together?
That's a great question. Thank you so much, Claire. And to answer, yes, we are still in process of having that new tool. It is one of our many ARPA projects, and so we are really excited about that. The new acuity tool is really going to be based off of pretty set clinical criteria. And that clinical criteria will match up and feed into any sort of medical necessity. So when it comes to the clinical criteria and things like that, there's a lot of standards and a lot of norms. And so there won't be any issues with aligning those. And Michelle, I don't know if you want to jump in and add anything more to that, but it's all really standard of practice, clinically based, best practice information. When you were developing a tool, it will be normed, it'll be standardized, and will fit with the medical necessity criteria.
Yeah, I don't think I'd add a whole lot other than you're correct. We have not, or I should say we are in the middle of that with the vendor that is doing it. We have been really careful to make sure that they have seen the rules and they're seeing these requirements. So the vendor, we spent quite a bit of time making sure they understood our program, what we have and all of that. So I think the other part is that will also be a public process. So I don't want people to feel like they're not going to see it and then all of a sudden it comes out. That's not the case, but we are just not at a place yet where we even have a copy of a tool. So just want to make sure everybody understands that will also include stakeholder engagement. They are already working with home health agencies or PDN agencies. So I think we'll have updates on that. I truly don't know. I don't want to misspeak on when we think the first stakeholder meetings will occur. So I will not even guess at that.
So that's super helpful though, Michelle. Thank you for clarifying. And I think it's really important to point out that process is also a very public process. And so thank you for mentioning that.
Candace, thank you. We have one more. Do we have time for one more, Candace?
I think so.
Okay. Pam R., please go ahead. You have 2 minutes. Thank you.
So I just have some concerns around the vagueness of medical necessity and the lack of a criteria or tool. I have a kiddo who was approved for 24-hour nursing within the administrative approval process. And we transferred agencies and we went from 24 hours to 13 hours. Same kid, same care plan, same everything. So that to me is just incredibly disconcerting, and that there doesn't seem to be continuity in what you're doing. We had a year par, we were only 2 months into it, and all of a sudden we're, in appeals for something that we shouldn't be in appeals for. So I guess I'm just incredibly concerned about the interpretation of medical necessity when we are that inconsistent.
So I will say that when you're talking about the administrative approval process, during that time, PARS and information was actually not being reviewed for medical necessity. So those reviews were not taking place during that time. And so what we are seeing is oftentimes there is a, like, why change now? Because now there is a medical necessity review. So that is the difference. It's not that there is a change in the definition or anything like that. There was no medical necessity review occurring, and now there is. And so that would be the difference. Also, you know, I do wonder if you're changing agencies, if there's something with the information that they're submitting or not. But we are always happy to have a conversation and to dig in a little bit deeper if necessary.
Candace, thank you. We are at the end of the queue for now.
Great. All right, well, let's move forward. Okay. So benefit limitations. This is currently how this section is written. It's pretty short and sweet. Next slide, please. And this is what we're proposing to change it to. So really clarifying that there is the utilization review process, and adding in the limitations that an individual must be able to be safely and effectively served in their home. So that's a really key piece there. Next slide, please. And additionally, adding a significant amount of additional information that helps clarify, makes things much more clear. Oh, I'm sorry, Heather, that I missed your question. I'll finish this slide and then I'll go back to your question in the queue. I'm just really trying to make sure that the limitations and the eligibility and things are very, very clear within the regulations themselves. And so we've added a significant amount here. I'm going to pause really quick, John, because I would like to take Heather's question that I missed, and my sincere apologies, Heather. Oh, okay. So Heather's question is, will the PDN provided at school issue be further defined or clarified? So PDN, so the school services is a really tricky one. We have what's called school health services, and that is how currently Medicaid services are provided in the schools. The schools are reimbursed for it, and then they provide the service. I understand it is not a perfect system. Additionally, the Centers for Medicare and Medicaid Services, so our federal partners, recently came out with some new guidance around school health services that our school health services team is currently digging into, and they're actually meeting with CMS, I believe, next week to kind of go through some additional clarifying questions and to obtain some more information. And so we are working with our federal partners to help clarify a lot of those questions around schools. So more to come on that. So hopefully that answers your question, Heather, kind of. I'm sorry that it's not a definitive. All right, John, it looks like I think we have another question in the comment box, and then Katie has her hand up again.
Okay. Do you want to handle that question? It's in the chat. Is that correct?
Sure, we'll start there.
Yes.
Claire said, what is an average non-medical person? I'm sure that's referencing a certain thing here. Sorry. Oh, can you go back a slide or forward or wherever it was?
It's 543C, the slide right before that.
Oh, it was the slide before. Christine was doing me a solid. Look at her. Okay. When a service community. Okay. So an average non-medical person is someone that doesn't need a clinical license or certification. So it's somebody who doesn't have that specialized or doesn't need specialized medical training in order to perform a service or a task. So that's what that means. It's historically, oftentimes the term unskilled has been used, and we don't like that term because it doesn't sound very nice. And so we don't, because it doesn't mean that a person doesn't have skills. And that's how it reads. And so we stopped using that term, obviously. And so I see Eliza's suggestion of maybe changing that wording based off of what I just said. We can certainly look into revising that to make it much more clear.
Okay, Candace, thank you. I believe this is John. We have one hand up still, I'm guessing, and that would be Katie. We're going to get to you. Anyone else who would like to ask a question or make a comment at this point using the speaker's queue? You can raise your hand. Use the little icon at the bottom of the screen. Anyone else? Okay. Katie, I'm not sure if you lowered your hand. Well, we have another person too. Erica, we'll get to you. Oh, there you are. Well, I think you came first, Katie, so you have 2 minutes. Thank you.
Sorry, thanks. I appreciate that this section, I think, Candace, you mentioned that the goal here is to sort of make things clearer by adding more pieces. I actually think it actually creates a lot of ambiguity because a lot of these, like in the 8543D section, a lot of this is already included in the medical necessity definition, is already included in the skilled nursing definition and other parts of like our big HCPF rules. And so I'm a little bit concerned that it actually creates more ambiguity. I think like number 3 that talks about observation or monitoring that does not require skilled nursing assessment. I'm not sure I know what that means, and I'd love like an example of what would be observation and monitoring that doesn't require that, because I'm just not sure I understand what that means, and so it's hard for me to imagine understanding how the rule will be implemented. And then going back to that C one that Claire was mentioning about the sort of average non-medical person, I sort of object to this, the addition of this, which seems to be trying to remove what is or limit what is considered a nursing service. I might be able to safely clean someone's G-tube because I've watched a nurse do it over and over and over again. But if it's in the Nurse Practice Act and it's defined as a nursing task, it should still be a nursing service. And so I think that section in particular is saying.
Correct. What we are suggesting is those activities that are not nursing activities are not covered. So something like G-tube cleaning, something like trach care, those types of things are traditionally nursing services. Something such as helping somebody that has no open wounds with a bath is not traditional nursing services. That is more of personal care. And so it's really trying to clarify the difference between what would be considered a nursing task and something that traditionally, whether or not you've watched somebody do it 100 times or not and know how, but traditionally would require a higher level clinical training to do versus not, something that does not require clinical training. Those are the differences there.
I totally understand the motivation because we already have a definition of skilled nursing that goes to the Nurse Practice Act.
Skilled nursing is a different benefit. This is the reason why we have these limitations outlined in this benefit, because it is a completely separate benefit under our state plan services. So private duty nursing is a separate benefit than the skilled nursing, the intermittent nursing.
Then I definitely think this section should reference the Nurse Practice Act and what is included, because the way I read this, the way it's written
Katie,
now.
you have 15 seconds. Thank you, Katie.
Again, if I can safely and effectively do a G-tube, why would this section not apply to me? I think I totally appreciate the motivation. What I'm saying is my feedback is the way this is written makes it very
Katie,
ambiguous.
that's time. Thank you. 2 minutes.
Okay, that's super helpful. And so what we can do is we can go back and we can take a look at that, because what I'm hearing you say is you're not reading it as a skill of an individual with clinical training providing clinical tasks. It's anybody that knows or has seen a task, whether or not it's a clinical task or not. So that's super helpful feedback. I appreciate that. And we will take that back and see how we can maybe reword it, maybe reference the Nurse Practice Act, whatever makes the most sense, certainly. So thank you very much.
Thank you. Erica, you're up next. You have 2 minutes. Thank you.
Sure. I put a technical suggestion in the chat, which hopefully will help clarify some of it. I think in looking at this, it seems like there's different ways we talk about PDN services being either continuous, skilled, complex, or just PDN. So hopefully that would be helpful. And then I just had a question if OCL has these types of sections and other sections of or other areas of rules that like do not include, if there's like a precedent for that, because it wasn't something that I've seen before just in other states' rules. So just want to throw that out there. And I don't know if you know the answer today, and that's okay if you don't, but just wanted to put it out there. Thanks.
Yeah, thank you, Erica. And thank you for that suggestion. I really appreciate that. And yes, we in almost all, and we're actually rewriting the entirety of our HCPF rules, which is an unbelievable task. If you guys have ever seen it, just one section alone was 195 pages. So the board is going to love us that month. Yeah, we typically have benefit limitations. It's actually how we outline things in our waiver agreements with the federal government as well. And so we always have a benefit limitation section. So it is pretty typical, normalized. Our survey partners at CDPHE utilize our benefit limitation section as well as part of their survey process. So yeah, there's definitely a precedent for this.
Okay, great. Thanks.
Of course. Thank you for the question.
Thank you, Candace. We have no more people in the queue right now, Candace.
Okay. All right. Well, let's keep going then. And full disclosure, I have no idea how many slides. I did not memorize the numbers, so I don't even know where we are in the presentation. So at some point, if I get to the end and seem surprised, it's because I am. This section, this is currently how the eligibility section is written. As you can see, it has the technology dependent, all of those things in here. So next slide, please. Still continued how it's written. It has a lot of examples in the regulation, which is interesting and difficult at times. So next slide, please. And so this is how we are proposing to change it. And obviously adjusting to member, adding some clarifying information, deleting certain things such as technologically dependent, because that creates a lot of questions, a lot of confusion, especially when it comes to our pediatric members. And so we are proposing these changes. Katie, I see your hand. I'm going to keep going for just a minute, and then we can always go back slides too if necessary. Can you go to the next slide, please? And then again, continued for eligibility. This talks about members that are aged 21 years and older. So really hoping to help clarify that members that are under 21 are not required to have, technology, all of those things. Members that are over 21 are. That is actually how it is laid out in statute. So it is statutorily required. We cannot deviate from that with our regulations because that's a statutory violation. Is there another eligibility slide, Christine? Let's go through. Okay. And so then yeah, we'll go back through. And then you go into the section for individuals that are 20 years and younger. So what we did is I heard a lot of feedback about wanting to have separate rules. And while we have one single benefit, so we didn't want to have two benefit packages for one or two rule sections for one benefit. Where there were variances is where we broke it apart, and eligibility is the key area where there's some variances. And so we broke it apart here, hopefully to make it more clear. Again, we're here for feedback. So I appreciate you guys letting me know what you think about that. And then obviously the highlighted area has been renumbered or reorganized. Is there another eligibility slide? And then here we go. Just continuing it on. So I know we have at least one question. I'm hoping we have more than just one question. This is a really significant, meaty area that I would like to have a lot of discussion around. And so hopefully there are other folks that want to chime in as well. Not that I don't value your feedback, Katie, I certainly do.
So folks, this is John. If you do have a comment or question, and especially if we haven't heard from you yet, would love to hear from other people. So you can please raise your hand in the webinar. It helps us to budget our time in this area. I'll be monitoring that. Okay, Katie, please go ahead. Thank you. You have 2 minutes.
All right, I'd like to do these 2 minutes on the first section that I think applies to all members, the kids and the adults.
Okay.
If
I
that's
have
possible.
Christine. She went back to the first slide where we started with eligibility. Is that helpful?
Perfect. Yeah,
Okay,
thank you.
Great.
So I think the first definition of going through to say what the interventions are for, so to improve health status, delayed skilled nursing level would result in this deterioration. That isn't accurate when it goes to EPSDT. What is medically necessary under EPSDT is broader than this definition, and I think this definition inaccurately and like unlawfully tries to restrict what would be considered eligible, what would be considered necessary for EPSDT. So
do you have a specific example of where you think this is too narrow versus where EPSDT is more broad to help us?
Yeah, so it says maintain or improve health status, and delayed skilled care would result in a deterioration. And EPSDT says it's a benefit that will or reasonably expected to prevent, diagnose, cure, correct, reduce, ameliorate the pain or suffering, physical, mental, cognitive, developmental effects of an illness, injury, and disability, right? So that is much broader than just these will be the negative effects. And again, I'm just not sure why that's on here when we have, as we've said, a medical necessity definition for all members and a medical necessity definition for kids for EPSDT.
Because this is a separate benefit. So we have to define what each benefit is. We have yes, I hear you, we have a medical necessity definition, but medical necessity is very broad. We have to define what the benefit is. And so that's the point of this. What I'm hearing you say is you think this is too narrow. Do you have a suggestion of a way we could adjust aside from just striking it?
I don't right now. I'm happy to think about that and follow up.
That would be good.
I would strike it. I think the bigger piece for me is that third definition of what continuous is incredibly limiting. And I think my
Katie,
reading
thank
of
you.
it.
You have 15 seconds, Katie. Thank you.
Okay, I had to read the EPSDT definition, so I feel like I'm not going to get a chance to say the most important piece here. The way that this seems like it's defined is that it has to be without cease, because the lay definition of continuous is without cease, right? And other states like North Carolina define continuous, and they say, and I'm quoting, nursing assessments requiring interventions that are performed at least every 2 or 3 hours during.
Katie, that's 2 minutes. Thank you.
Okay, so what I'm hearing you say or suggest is that, and I know you have more comments, so feel free to go ahead and put your hand back up, Katie, because this is a really meaty section, and so I want to make sure we do have a chance to talk through all of it, just to be clear. What I'm hearing you say is that the continuous perhaps needs to be defined a little bit more clearly. I will, let you guys know the word continuous is in statute. So we are required to use that term in defining what PDN is. It is statutorily required. And John, to Katie's point, she's wanting to respond to my comment back to her, if that's okay. I'm fine with that. And I think it would be helpful just to, at least to get through that piece.
Absolutely. Katie, please go ahead.
Thanks. Yeah, it's from the federal, so I totally appreciate that. My point is only that it seems like the definition being used here is the lay definition, which means without cease. And if that's taken to the end, right, that would mean that there would be no PDN services for anyone not needing it 24 hours, because why would I need constant without cease intervention for only 2 hours, right? I would need it for the whole time. And all I'm trying to say also is just that other states define continuous in a much different way, like, once every 2 to 3 hours, and that still counts as the PDN benefit. Thanks.
And Candace, do you want me to, I think, Katie, this is really helpful. I just want to respond quickly. I think part of it is, I hear what you're saying, that we need to be a little bit more clear, but think of it this way. There is such a thing as continuous nursing for an hour or two. That is continuous. It's the nurse has to do something continuously of an assessment, an intervention for a period of time. So I think, Candace, it's a really good point of us being able to explain that it's not restricted to 1 hour, 8 hours. It doesn't automatically mean 24. It's what is, and we are also trying to make sure that there's a difference between continuous and intermittent, which is in the different benefit. So to your example of you do something here and 2 hours later, you do something different, that's actually could be intermittent. Again, case by case review of the medical necessity of every individual, but at a broad term, if you do something and you stop and it takes 15 minutes or 30 minutes and then you don't do anything for another couple hours, that's intermittent. And I'm being broad here versus a continuous. So I think what you're asking, Katie, and I think it's good for us to kind of figure out how to explain this is there a time limit, I think is what you're getting to, or what amount of time would be considered continuous where then it could stop? I think it's a really good point to make. So I
Agreed.
I hope that's helpful, Candace.
Yeah, I agree. And that is helpful for me. So thank you very much for that point, Katie.
Okay, thank you all. Dana, you are up next. You have 2 minutes. Thank you.
Thank you. And I'm sorry, I have not had a chance. I just have found out about these meetings, so I have not had a chance to read through the document and all of that. But I'm a mom of a special needs kid and have been in the private duty program since she was a newborn. And I have always had a question around, is it statute that says that we have different criteria for adults and children? Again, my daughter's care did not change at 21, right?
Mhm.
But the benefit changed at 21.
Yeah.
And it sounds like in this document, we're trying to say, so for pediatrics, there's one set of criteria for what's medical necessity, and there's another one for adults. And that doesn't make sense to me, but that just may be my ignorance. So I apologize.
No apology. Please, I appreciate the question. It is actually federally required. So there is what's called a federal regulation called EPSDT that requires states to do things differently. And so that's why. And the EPSDT goes through age 20. So on the 21st birthday is when things change. We did recently update our limit to private duty nursing for adults. It was capped at 16 hours, and we were able to increase that to 23. Statutorily, we can't go to 24. That's a Colorado statute. And so we increased it to as far as we could without violating this statute. So we did increase that, but there is still that hour difference.
But what we consider medical necessity, some of that criteria is going to be different between the two as well.
Yeah, a little bit.
Okay.
I know it's not lovely.
It's not very logical when you're in the thick of taking care of kids that have issues, but yeah.
I agree. It's navigating all those state statutes and federal ones that sometimes don't work together is not helpful for you all.
Candace, this is John. We, up to this moment, we didn't have any hands raised, but there's a comment in the chat I would draw your attention to.
Okay.
And then we have a hand raised as well.
The comment from Claire?
Yes.
Okay. Okay, so there are several terms and phrases in this section that should be defined. Yes, we are going to be discussing a definition section. So we are going to be going through the definitions in our next meeting. So yes, very much so, Claire. Thank you very much for pointing those out. And we will note those ones that you think would be helpful to define. So thank you very much for that feedback. So no, it's not that there is a federal requirement that Colorado limit the PDN benefits for adults. It's actually a state statute. And then Katie has another comment that it indicates that a provider determines what is medically necessary. So a provider absolutely has to make a recommendation and for medically necessary services, and then it goes through a full medical necessity review with our utilization contractor, our utilization management contractor.
I would say, Candace, on that, and I think that's something too we should discuss more, Katie. I think, and I don't know if having a physician explain this would be better, but I'll give you it from my perspective. The physician that is ordering is absolutely making a statement and a recommendation that a care is needed that is medically necessary, or a test, or a med, or a lab. So take it across anything, but that in itself doesn't always mean that they know. I'm going to say in this case, they know that they need assistance. They know that it's maybe skilled, but they would not have the insights into our benefit of where that fits best. And so I think it's kind of this idea that the physician orders it, but it doesn't mean that that test is absolutely, I don't want to use the word correct. I'm trying to think of a better way to say it, but there may be something that is more appropriate, or a recommendation, like say a pharmacist can call a physician and say, hey, you ordered this, but let's talk about it. Maybe you should order Y instead of X. And so think of it as a matter of they are addressing and saying, yes, it's medically necessary. They need something. And I'm being very broad. And then as you start looking at it and thinking about, okay, well, where does that fit to provide those services? So again, kind of coming back to, they need help. I think they need help from a nurse. So I'm going to write an order that says they need PDN, but when it's reviewed, it's actually, hey, they actually only need intermittent nursing, right? So again, it's not saying that they don't need assistance. It's where is the best benefit for that, which is not something a physician office would likely know. And Dr. Walsh is here. He'll say it much more eloquently than I will.
No, I won't. I think you accurately described it. The physician recommendation is a starting point and very critical. However, it's subject to review and in some cases, examining additional records, because sometimes a physician's recommendation is based on limited information even from them. So the full picture needs to be considered. I think you accurately described it, Michelle.
Thank you, Michelle, and thank you, Dr. Walsh. And looks like we have
one hand
more
in the
hand raised.
queue that's been.
Oh, now we got
going
two.
All right. Okay, Pam, you're up first. You have 2 minutes. Thank you.
I'm just curious when you talk about tasks, nursing tasks, is there any place in this? I'm trying to read it on my phone. It's not working very well, but that nursing assessment is addressed within this continuous definition.
Michelle, when we're talking continuous nursing, that includes assessing.
Assessing and interventions.
yeah,
And I thought it
interventions.
was, but I think it's a good point for us to go make, and let's double check that. But there is and Valerie will say it better than I will as well, but it's a nursing task that is continuous in nature that also requires a nursing level assessment and intervention in that time period. And I'm being very broad here. But yeah, I think we make sure that we are saying it specifically like that. I think that might be in the medical necessity part, but again, I might not remember.
Right. No, and I guess that's my question, because it doesn't seem when you've got a kid on oxygen or a kid on a ventilator, or you have a kid that's, being G-tube fed, and maybe it's a bolus feed, but they have feeding tolerance difficulties, and you're assessing, before, during, and after to make sure that they're not aspirating, right? That's an assessment that then goes into their next feed, or they vomit and aspirate and need a neb and a CPT. Like, that's not, do you know what I'm saying? I'm just curious if that's going to be adequately identified within this, because there's a lot of nursing assessment that goes on even with a kid that's receiving 3 feeds a day.
Actually, Pam, I think you're making a very good point, and you're bringing up the example that we're actually speaking to, or at least what I would speak to, is to your point, every single child and adult is evaluated independently. So yes, you have a rule that talks about criteria, but we want to stress that, to your point, every single case is different. So we are not going to say, well, this person has to your point, a trach, so we have expectations of what their care is. There's different variations. There are stable trachs, there are not stable trachs. So having that documentation is key. When those provider notes are talking about, to your point, it's not just starting a feeding. They have known aspiration pneumonia. They have all of these things. So I really want to stress that that's the whole point of this, is in some ways being more, less examples and a little bit more broad, because we do not want to have anybody feel that the rule is going to dictate the outcome. Every case is reviewed individually. Every case is based on the notes submitted. And we really want to push that these are independent. We are not, and we do not compare, because that's another thing that we do hear a lot. And I understand, I will tell you, as a nurse of 30 years, I totally understand where people get confused and say, well, wait a minute, I have 2 kids that are similar, but this was approved, this was denied. And that's where you get into nobody's the same. Every case is different, and the documentation that supports it could be different. So, and I think that's where we're also trying to really be clear, and we've spent so much time with the agencies. We want to get to the yes, as Valerie says, but it's, getting the agencies to understand the documentation has been, I think, really helpful. But I don't know if that's helpful, Pam, but I really want to stress that. That's why every child will be looked at in that independent way. So not sure if that's helpful, but let me know.
No, I mean, it's helpful. I just want to make sure that the word assessment or monitoring, or because that's not a task, but it is a task, and it is 100% something that cannot be delegated.
Yes, absolutely.
Thank
So
you.
thank you, John. Sorry. So Pam, if there is, when you are maybe able to pull it up on something a little bit larger than a phone screen, and you can take a look at the wording if you think that there is an area where we can clarify or make it more clear that assessment is part of it, that would be helpful feedback for us.
Okay, thank you all. Claire, you are up next. You have 2 minutes. And Candace, there are comments from Galia in the chat, and she also is raising her hand. Claire, go ahead. You have 2 minutes. Thank you.
Thanks. I just wanted to suggest that there be some reference to a definition of intermittent home health services or explanation of it, because, you know, and I'm speaking particularly about Section 4A2, requires continuous skilled nursing services that exceed what can be managed with intermittent home health services. I know individuals who have been approved for 24 hours of PDN for many, many years, and the department has told them you can manage with intermittent. There needs to be some clarification. My understanding of intermittent, it's the task base, and that the nurse is sent out and paid in a different way, sent out to do a particular task, and technically is not supposed to be doing something that's not on her task sheet, even if it would, if something occurs while the nurse is there that would require skilled nursing intervention. Thanks.
Thank you, Claire. That's helpful feedback.
Thank you, Claire. Galia, you're up next. Thank you. You have 2 minutes.
This is Galia Spachaska. Can you hear me?
Yes, we can.
Yes.
Hi, I'm an RN FNP, and I'm also a mom to my son. I would really caution you to really look at the wording of this specific slide, because it's very concerning to me. First, definition of continuous versus intermittent nursing. And I think that that is a slippery slope, because the only definition that was ever identified was in a federal lawsuit that talked about private duty nursing. And intermittent home health services is task oriented. That is correct, that Claire pointed that out. And that is not private duty nursing. Private duty nursing is continuous. So we need to identify what continuous nursing services or private duty nursing is in a tangible criteria. The other thing is the nursing task thing. I would identify that as, again, task oriented and part of intermittent home health nursing. And so if you're saying that private duty nursing is only nursing task oriented, it does exclude assessment, monitoring. I can tell you that there are many of our children that have specific physician orders and protocols, like my son does. If this happens, do this. Based on this assessment, do this. Based on that, do this. And that is all based on RN assessment. And so putting it as a nursing task is questionable, because a lot of our children that receive private duty nursing services receive it because those things are interventions and they're based on nursing. So I just wanted to make sure I pointed that out. Thank you.
Thank you.
That's helpful, Galia. Thank you so much. And so what I'm hearing from both you and Claire is that having the task-based wording is creating a lot of confusion between intermittent nursing and PDN, and then whether or not we have assessment in there. So I think if you all have suggestions and ways that we can clarify, please send them our way. But in the meantime, we can also be working on some adjustments there to hopefully make it much more clear. So I really appreciate that feedback.
Candace, this is John. We have no more hands raised. We do have a few things in the chat I would draw your attention to.
Okay, I will do my best to go through a number that we can go through, a number of comments here. Okay, so Katie, I appreciate your feedback. It looks like we have different phrases describing nursing services. And so it's hard to provide feedback on a draft using words that have not yet been defined. I appreciate that. Thank you for that feedback. And then she provides some examples, so that'll be helpful so we can add that to our listening log. So thank you for the specific examples as well. And then Erica's agreeing with Claire. So thank you. We can follow up on that. That's one that we just talked about that we'll follow up on. Erin is providing all sorts of ways that you all can provide additional feedback. So thank you. Are there any others that you think I missed, John?
No, but no. And I would point out, I know you have one screen there on your lovely mountain hotel, but we have 6 slides left. So as the team
Okay.
leader, figure out how to budget your time, but we have 6 more slides.
That's super helpful. Thank you, John. Yes, traditionally, I'm able to have multiple screens and do many more tasks, but like I said, I was attending a conference I was presenting at yesterday. I'm much more limited today, so thank you for that support. Okay, so let's keep going. We had a lot of comments on that first slide. We went through this and we looked at it briefly, but I do, to Katie's point, want to make sure that we have a chance to kind of go a little bit slower through these next 2 slides and see if there are any additional comments that we haven't already discussed a little bit in both this one and the next one. So it's the 21 years and older and the 20 and under slides. Katie. Sorry, I call on Katie. That's John's job. That's not my job.
Katie, you have 2 minutes. Thank you. Please go ahead, Katie.
Thank you. I just wanted to comment. I put a bunch of comments in the chat already, obviously, but I wanted to comment on the over 21 8A double I, the very last one. And just mention the language of consecutive tasks at a level that cannot be delegated. I'm sorry, I lost my notes in front of me. Basically, my point is just that I wanted to make sure to be clear that it's where professional judgment is required to make the decision to delegate, right? And like, it's only when it can be and is delegated that it doesn't, that it's no longer skilled. Am I making any sense? What I'm trying to say, like, here's an example, right? Like, I'm a nurse. I can delegate this task to the CNA that's present, but I don't feel comfortable delegating that task because the CNA is not prepared to do it because they had a bad day, or I don't feel comfortable because this member is incredibly aggressive and this CNA is not prepared to deal with and, you know, requires more help because this member has a specific need. And so I just want to make sure that anytime we're talking about delegation, that the language should be if it can be and is, right? As opposed to whether
Gotcha.
Just can be, if that makes sense.
Right. Because it's based off of each individual's needs, right? So can be and is, that's a helpful suggestion. I can see Michelle thinking about that as our clinical chief nursing officer within the department. And so she and I can certainly chat a little bit more about that, but that's really helpful. Thank you. Because that is an important distinction for sure.
Thank you. Galia, you're up next. You have 2 minutes, please. Thanks. Are you, let's see, perhaps she changed her mind.
Or maybe she lowered her hand instead of coming off mute.
Hi, sorry. Can you
There
hear
you
me
go.
now?
Oh,
We can. Thank you, Galia.
Thank you.
Okay. Again, I just feel like this slide in comparison to the other slide uses different terminology, and the terminology should be fluid within the PDN rule because now you're identifying complex skilled nursing, which is totally different than continuous nursing. And then you're also identifying all of these specific tasks, which are, I understand that you're trying to put in multi-step systems and all that, but that's all identified in the Colorado State Nurse Practice Act. And I just worry that being this specific in this wording and then adding complex skilled nursing as another definition that needs to be identified with specific criteria, you're throwing in too many different words to describe the same thing in a very, very complex way. And again, this is not a Board of Nursing State Practice Act, yet you guys are identifying criteria like it is. And so if we're going to actually put in specifics like this, then the Board of Nursing needs to be involved because we have a Colorado State Nurse Practice Act that identifies all of this, and this is unnecessary.
So that's really helpful, Galia. The feedback that perhaps there's, and this is not, I think Katie brought this up earlier too, of having different ways that we are describing the nursing and maybe being a little bit more consistent in our terminology. So that's super helpful feedback. Thank you.
Well, and I just think making it so specific is going to actually deny access to needed private duty nursing care for children under the age of 21. And I think that writing it in this specific manner is really not needed. There is no other there's no other state private duty nursing rules that I've read through, and I've read through about 15 nationally that are this
You have
specific.
15 seconds left. Thank you.
So I would urge you not to go this route, because this is going to be a big fight. And then you're going to have to compare the Colorado State Nurse Practice Act into this. And I would encourage you to make it more broad and not as specific, because that's really concerning.
Thank you, Galia.
Yeah, thank you very much for that feedback.
Let me just point out to you, we have about, looks like 11 minutes left in the scheduled time for today.
Okay. I do know that we have a couple of comments. Yeah, stay on this slide if you don't mind, Christine. Thank you. Okay, so I want to read those really quick because I know Katie wanted to highlight one of them. Okay, so Claire wrote, if taken to logical conclusion, would seem to mean that any member who has a family member who has learned how to provide skills. Okay, so that goes back to Katie's point earlier about who can provide a task. And so we have discussed that we need to provide some clarity around that language there. What is going to happen to children who are not technologically dependent but need PDN services turn 21? Yeah, I mean, unfortunately, the technology dependent piece is defined in statute. It is Colorado statute that an individual that receives private duty nursing is technologically dependent. And so, yeah, I mean, that is going to be an issue, and that is concerning for everybody. But we cannot violate our statutes when it comes to that. So that is absolutely in Colorado state statute. I see that raised quite a few hands there. So we can go ahead and take those, and then we're going to move forward to make sure we hit our time and get through the rest of these slides.
Okay, thank you, Candace. So folks, there's 3 hands in the queue. We are limited on time. I'm going to keep time pretty well and ask you to be as brief as you can, and then we'll stop after these 3. Galia, please go ahead. Thank you. 2 minutes.
Hi, this is Galia Spitelska again, and I am going to reference the Colorado state statute. Does not state that private duty nursing patients require to be technology dependent at all times.
It does.
The state statute, and let me finish, because it's my time. I have my 2 minutes. I would like to say my 2 minutes. The Colorado state statutes actually identify specific criteria, and it's listed. And it also states that if it's medically necessary, and that there are always exceptions to the rule. So I've read that Colorado state statute, and it's one of the things that's on the criteria. So to sit there and say that children require private duty nursing have to be technology dependent with continuous nursing services, complex skilled nursing, and doing all of these identifications, that is not the truth. That is not the truth at all. That is not what the state statute says. And I would tell you that is going to legally come up on multiple levels, because that is not the truth. My son requires CPR at times and life-saving interventions, and he is not technology dependent. And I can tell you that his private duty nursing since the age of 4 has saved his life multiple times. And the only reason that this child is alive is because of his private duty nursing services, the assessment, the monitoring, the medications, his treatments, his physician orders, everything. And so I would urge you to reread the statute, because I have.
Thank you very much, Galia. To be clear, I never stated that the technology dependence actually applies to children, because it does not. The statute and the technology dependence applies to adults. And I will ask my team if they have that statute to put it in the chat for folks, so that they can all, everybody can have the same reference point. John?
Thank you very much, Galia. So next up is Claire. Claire, you have 2 minutes. Thank you. Claire, are you with us?
I think you're still muted, Claire.
Well, we can move to Katie and come back to Claire in consideration of our short time here. Would that
Thank
be
you,
all right,
John.
Candace?
Yeah, that works great. Thank you, John.
Okay. Katie, you're up next. You have 2 minutes. Thank you.
Thank you. So for this kids section, I just wanted to bring up a couple points. The first is just that that definition. I get just nervous anytime we're restricting medical necessity, which again, I know that's not the intention, but I feel like this should just say members aged 20 years or younger that demonstrate medical necessity in accordance with EPSDT. That's how I think that it should look, because we're going to define medical necessity, and that's sort of the whole point. I also think, so then there's a new word introduced, which is constant skilled nursing. Is that different than continuous? Again, just sort of thinking through those definitions. And as we've said a couple times, I think in the chat, there's just a lot of new words put in various places that make it hard to know what's going to apply. And then I also just wanted to say, I think that number 4 is just kind of offensive. We're talking about nursing services. There's no world in which age-appropriate childcare responsibilities are nursing services. So this seems to come from some place like we're assuming that parents are trying to defraud and use this service when they don't need it. And I find it offensive. I think if I were a parent, I would find it offensive. It's completely unnecessary because we're talking about nursing services. These are obviously not nursing services. So I absolutely think that should come out. And then I also, again, think that last piece, number 5, that the severity makes the services medically necessary to ensure member safety. No, it doesn't have to be member safety under EPSDT. That's just not a requirement. So again, a lot of these just seem, and again, I know that's not the goal, but it seems that we're trying to limit as much as we can and sort of chop things off by saying things like ensuring member safety. No, that's not the standard, right?
Katie,
So
you have
that's
15 seconds.
Thanks.
15 seconds. Thank you.
Thank you very much, Katie. I appreciate that feedback.
Okay, Claire, hopefully.
Yeah, sorry about that. I had technical difficulties.
That's great.
No
2 minutes. Thank
I
you.
just wanted to, going back to my comment in the chat, I just wanted to clarify that, what I meant was, what happens because of this dichotomy between children and adults, where children can have comorbidities and get PDN, and they don't have to be technology dependent, but adults do for at least part of the day. What's going to happen to those people when they turn 21? What is there a plan by the department to make sure that those people get service? And
So
that's all.
Yeah, no, thank you, Claire. I appreciate that. We do still have another nursing service, and that is the intermittent nursing. And so traditionally, we have folks that transition over to intermittent nursing. I will say it's really rare that there is a huge issue or a huge cliff in these scenarios. But there are still nursing services that are still available to adults that need them as well.
Hey, Candace, I'm wondering, so Claire, I'm wondering, I think what you might be asking as well is maybe does the department have, I'm going to say, a document that kind of describes the process? Because one of the things we've talked about, and Valerie, I can't remember if this was implemented or not, but I think it's on our list of what are we doing to identify kids maybe at year 20 when we know they have complex needs, and then we are going to get the RAE involved. We get the CCBs involved. Like we're thinking about how do we start that process early so that it's not this, 21 and then you start planning. So I want to recognize what you're saying and the fact that we talk about how do we make that transition easier and start evaluating to Candace's point, other things before. So I don't know, Candace, I don't know, Claire, if that's kind of what you're getting at, and that's what I'm hearing.
In part, but also I want to address something that Candace said. It's like that brings me back to my complete and utter confusion about what you mean by intermittent, when if this person needed continuous care under PDN services and now they're going to get intermittent, that's the department's solution for them. And I just want to make sure that, it doesn't seem right to me that there is this dichotomy between kids and adults. And that's just my general opinion there, right? But and then the other thing I wanted to mention here was that, oh shoot, now I forgot it. Sorry, I'll have to put it in the chat.
No, that's okay. Thank you very much for your comments, Claire, and I appreciate your feedback. And I hear, there is, it's hard, right? When we have statutes that are written in such a way that are very different than kind of what we're required to do from a federal perspective for pediatrics. And so I want to recognize that it is 100% hard and difficult. And so we are very close to running out of time, so I'm going to go ahead and move us forward. Next slide, please, because we went through that one. No, it was brief. Okay, this is a section, so application procedures. This is how it was currently written. We have renamed this from application procedures because it's pretty outdated. Next slide, please. Into the hospital discharge procedures. So to make it very clear about discharging an individual from the hospital. So you can see a few things that were struck there or suggested striking there. Next slide, please. Okay, so that last slide, I know we didn't get a lot of time to spend on, which is okay because we're going to talk some more about it, I promise. So next steps, we are going to have another meeting. It should be in October. I don't have the exact date in front of me, but we've been doing an every other month cadence. We're going to, yes, Michelle.
Sorry. I think I'm seeing a lot of questions specific to intermittent, so we don't have time to dive in. Here's what I'm going to recommend. Examples of intermittent tests that are performed by nurses is part of the PAT. It is at the end, and it is a separate tool. It's the intermittent nursing tool. I think that would be a great thing for people to take a look at before we meet again. So you can see, because I see a lot of questions about, well, what do you mean by intermittent? And it really shows certain tasks that are considered intermittent. And so again, I think that might be helpful for everybody. I just want to throw that out there. We could send it out or however we want to share it.
And thank you very much, Michelle. That's helpful. We can post that to our PDN site so that folks can see it and look at it when they have a chance. Okay, so all of our documents, the recording, the draft of the rules, the slide deck, everything will be on our private duty nursing webpage, so you can find everything there. We are happy to take feedback in a variety of ways. We have our Google form that you can, I know has been put in the chat a few times. You can submit things. You can email it to our homehealth@state.co.us email address. Just put in the subject line the PDN rule comments. It just helps us identify it and make sure we get it transferred over to our listening log. You can call and leave a message with your feedback, all of those different avenues. Plus, of course, all of the comments here have been logged as well. Next slide, please. Again, here's another way to view the different ways that you can provide public comment. You can also fax us or mail us a letter as well. Next slide, please. Okay, and so I know this says questions. We actually don't have time for questions. Our meeting is scheduled to end exactly at 11:20, and we are at 11:20. Galia, I see your hand up. My apologies. We just don't have time for any additional comments. Please submit your question to one of those avenues that we just threw up there so that we can respond to you. Again, all of the comments, the feedback are going to be posted to our listening log. Those will be online, so you can take a look at that. We are responding to each of them individually. So it's a very long listening log, just so you guys know. It's talking 300 comments per meeting that each have an individual response. But please go ahead and take a look at that. Continue to submit your feedback. Next meeting, we will go through definitions and we will have a entire draft to look at. I may look at actually extending that meeting because it is going to be huge. If we are not able to get through everything that we need to in one meeting, we'll have a second meeting or sixth meeting, I guess I should say. We'll have another one. So I want to make sure everybody understands that we are not going to take these rules or submit them to the Medical Services Board until we have had a chance to go through the entirety of the draft together. And so just please know that if that means we have to wait until January to submit things, we'll wait until January to submit things. We need to make sure that everybody has an opportunity to fully engage and submit their comments. So thank you all so much for your time. Thank you for your feedback, and really, truly thank you for your participation. It is so helpful to make sure that we are able to get these rules revised in the best way possible. I hope you all enjoy your absolute very last day of August this year. And I will see you all in a few months. Thank you. Take care.